Hi, my name is John Pilcher. I'm a bariatric surgeon in San Antonio, and this video segment is addressed to people who are looking at bariatric surgery but who may feel like it's a little bit too intense for them. This is talking about people who are a little sick from the weight or under some strain from the weight. Maybe they need to lose 50, maybe 70 pounds, and they've looked at sleeve and they've looked at gastric bypass and just felt like these operations were a bit too strong or a bit too intense for them. And this is a reasonable concern because these same operations, the sleeve and the gastric bypass, can sometimes help people lose 200 or even 300 pounds in the right circumstances. So what happens with people who need to lose smaller amounts of weight? It turns out that news is good for people who are at the early stage of obesity as well as those at the advanced stage of obesity, because the sleeve and gastric bypass tend to cause weight loss that's kind of calibrated to the amount of weight that a person needs to lose. It's interesting to learn how these operations work. But first we need to go back a little bit and understand where obesity comes from in the modern research sense. Now, the old school thought process was that obesity happens from a set of bad choices and bad habits, and the current understanding is that obesity is coming from an abnormality or an imbalance in the biological control system that controls weight. I've talked about this much more extensively in a different YouTube video, so I'm going to leave it alone here. Just suffice it to say that there's kind of a fat thermostat, or what we sometimes call a fatostat, in the body that's maintaining the body at a weight level where the body thinks the weight needs to be. Very often, the bariatric operations are understood to help with weight loss by mainly blocking eating or restricting food intake. And it's true that both of these operations have a much smaller stomach, and it's true that especially early on after surgery, patients can't hold as much food. But the reality is that both operations are actually working by adjusting this fatostat. They're actually going in and having a direct hormonal metabolic impact so that not only can a person hold less food with the smaller stomach, but more importantly, the person wants less food. So while these operations are having a powerful effect in reducing the intensity of hunger and changing this fatostat to a lower healthy level, happily they are not interfering with the protein storage mechanisms. The body also has a health monitoring system, and so what we get typically is that a patient has a smaller but still a healthy appetite, and when the body needs some nutrition for energy, for building muscle, they'll have hunger, and if they follow that appropriate hunger, then they'll eat a normal healthy amount of food. The practical patient experience is that when they get to be about 6 months after surgery and the stomach has healed to a large degree, people can eat substantial amounts of normal healthy food, but they don't want that much as long as they continue to need to lose weight. The other thing that your surgeons do as a matter of monitoring your nutrition level is to keep track of your weight loss trajectory. And if it looks like an individual is going to go too low with their weight over time, then it's pretty easy to teach them how to take in more calories and hopefully healthy calories and in a sense cheat around the bariatric operation. You won't hear your surgeons teaching that from the get-go. This conversation about using bariatric surgery for people with moderate excess weight is not just a theory. There's lots of experience in using bariatric operations for people who have just moderate excess weight but who have other advanced medical conditions. For example, gastric bypass is often used for people with really severe heartburn and reflux because it's a great operation for that condition. So if we take someone who has reflux and is only 15 pounds overweight and we do a gastric bypass, those people tend to lose maybe 10 pounds after their operation while having substantial reflux benefits. And by the way, this is the same operation that we're using for people who need to lose 200 or 300 pounds. It's just that the operation has weight loss that's kind of calibrated to that person's starting weight, and as I mentioned earlier, it does not interfere with the nutrition process. Now, it's obvious that the management of most problems, including the obesity disease, is more effective when you start at an earlier stage of the problem. And so that's why it's important for people to understand that it does work well to use these interventional treatments for people who are at an earlier stage of the disease process.